Yeah, thanks for joining us on the webinar today. I'm Elliot Stone, CEO of MedQuest, and your moderator. Joining me is Dr. David Wall, a pain management specialist of Ortho USA, our partner, along with CEO George LaRoe. At the end of the webinar, we'll field your questions. As a former practicing PI attorney and litigation consultant for the last 25 years, I've developed an ability to identify new industry trends, often before others, such as medical records offshoring. I believe with Ortho USA, I discovered a powerful new partner and service that can dramatically increase the value of many soft tissue cases by $50,000 to $100,000 or even more. Ortho pays for and provides quality medical care to injured accident victim clients that lack health insurance. It's been standard in the industry for attorneys to locate doctors who will take liens, typically charging exorbitant fees due to the risks involved. These doctors are then often subject to collateral attack for having a stake in the case outcome. Or attorneys will look for a funding company that typically has little flexibility or sympathy for the client if there's a poor settlement or case outcome. Often the client's out of luck. Also, typically treatment options are often limited to chiropractic manipulations or pain injections or PT, which limit the case value, or major fusion surgery, but often nothing in between. Patients with small, mid-sized herniations or facet injuries are just out of luck. But finally, though, there's another option or a middle ground that's available through Ortho USA. Minimally invasive surgery with a 90% cure rate that builds your soft tissue cases into surgical ones, maximizing case value. We pay the doctors, the surgery centers, anesthesia promptly, and all the non-recourse lien on the case. Now, minimally invasive surgery is an option where the chiropractic or PT treatments and injections fail, there's persistent neck or back pain, or the MRI, as I said, shows small to mid-sized herniations. Or even when the MRI is normal, but facet capsule injuries are diagnosed. Or finally, client is not a candidate for fusion surgery or simply refuses to undergo it. Now, here we can see a moderate cervical herniation that could easily be treated by our surgery. Here we see a herniation in the lumbar area. Now, some of the advantages of these type of surgeries include the success rate, typically in the 80 to 90% range. It's less costly than open surgery, so it can be done on lower policy limits. It's outpatient, quick recovery, usually within a week. There's lower risk than the major surgery. It's a conservative option, obviously, and the client can always progress to fusion surgery if indicated and necessary. Now, I'd like to introduce Dr. David Wall. Dave's a pain management specialist, performs these surgeries, and he'd like to speak about the different options available and even show you some clips from actual surgeries he's participated in. Dave, take over.
Okay, thanks, Elliot. Okay, welcome everyone. So I'm going to give just a brief overview of what these surgeries are, so you have at least a basic understanding of what we're talking about when we're talking about the type of minimally invasive surgeries that we're discussing. So the first let's talk about the low back or the lumbar area. So the low back area, it says on the slide, we call the lumbar PDD, meaning lumbar posterior disc decompression. And then the second part of that says with facet capsule thermoplasty. I'll fill that part in a little bit. But essentially, the global fee for, if you include surgical fee and facility fee, anesthesia fee, generally is around the $50,000 is what the bills that are being generated by this procedure. It's indicated for persistent low back pain. The patient can or may not have leg pain. It's not a requirement that they have any type of radicular or leg symptoms. And of course, we like them to have completed physical therapy or chiropractic care. And you would see a herniation, obviously, on the MRI if they're going to undergo a lumbar disc herniation procedure. And essentially, the patient undergoes what we call intravenous general anesthesia. So we're putting the patient to sleep, but without a breathing tube. Most of the anesthesiologists now are become pretty adept at doing these without. So the patient does not have to have a breathing tube in, but they are essentially asleep. We put in a tube, which we call a decompression device. So we make a small incision, put a tube in, and the tube goes into the disc. So no bone is taken out. The tube goes directly into the disc, sort of like you see when the patients do arthroscopic knee surgery, all through a tube. So we put a tube into the disc. Once the tube is in the disc, then we can work with that tube. And there's different things we can do inside the tube, from some basic stuff to heating the disc up from within, which when you heat the disc, it actually creates some shrinkage of the jelly that's inside the disc, which we call the nucleus pulposus, that jelly. And if you can shrink the jelly, you can leave room for the herniation to come back in. And I kind of explain it to patients like if you have a tire that has a weakened wall of the tire, what do? You get a bubble. Well, if we can take some of the air out of the tire, that bubble will go in. And while this is an oversimplification, it works well from patient understanding. And it works pretty well. Again, like all surgeries, you have to pick your patients right. But if you pick your patients correctly, then we have a 80% plus success rate usually. Now, if you see at the top, it says lumbar PDD with facet capsule thermoplasty. Well, what is the facet capsule thermoplasty? Well, that is, I think we have another. So go to the next slide, if you would, Elliot. I think we have a slide on that. Yeah, lumbar facet capsule thermoplasty. So that's basically what we're doing. Is we're going down with also a tube onto the facet joints themselves, because if you have enough trauma to cause a disc herniation, you generally have enough trauma to injure the capsules or the tissue that goes around the facet joints. And we can try to repair these with a laser. And so we go down with the laser and we try to repair these. So most of the time, not all the time, but most of the time when we're doing the lumbar disc decompression, what we call the PDD, we're also repairing the facet capsules as well with the laser. Now, this slide here shows that the lumbar facet capsule thermoplasty or the lumbar facet surgery can be done by itself. If in patients who have they have back pain, they actually may even have some leg pain, which we call referred pain, not really coming from a nerve, but it's referred pain. And they've had therapy, but they've got no herniations in the MRI, and nothing to suggest that the disc is the causation of the pain. Then we go in and try to repair the facet capsules, and so that's sometimes this procedure is done by itself, not necessarily along with the lumbar disc procedure. So it can be done by itself or as part of the lumbar disc procedure. Okay, next slide, please. Similarly, in the neck, we can do a disc procedure as well. Again, this time it's done from the front. So the patient's asleep. You put a tube in. You make a tiny incision. It's less than probably an 1/8 inch incision. It's more like a nick in the skin, just enough to put a tube in. You put the tube into the disc, and then you put essentially wire with a heater through the tube, heats up the inside of the disc, causes shrinkage of the jelly inside, and hopefully enough shrinkage that the disc comes back in. And again, we see about an 80% success rate with this. It's indicated for people with obviously disc herniations in the neck and with neck pain by itself or neck pain with arm pain. So it can be done, and it's done as I just discussed with you. The global fee generally for that, by the time you get the surgical fee, the anesthesia fee, facility fee, you're probably in the 40 to 50 range. Also, maybe a tiny bit lower than the low back. Low back's probably in the 50 to 60, and the global for this, the bills that are going to be generated are in the 40 to 50. So that's the cervical. Go ahead, next slide. And again, some people are doing the facet capsuloplasty in the neck as well. That's one way to go about it. And for those facet capsule injuries, there's a few options you have, but that's one option is this facet capsule thermoplasty to go after these facet injuries in the cervical spine as well. And so we'll take you through a few pictures. I think we have a few pictures. So this is a low back one. So you see small incisions being made right there. And next slide, please. Now we're taking, I've already put the initial, so you can't quite see it. At least I can't. There's a needle in there. And we're putting a guide wire through the needle. Okay, next. Once the guide wire's in, we have a guide wire. So the guide wire's in the disc now. It's in there, and I can see it under fluoroscopy. Now that thing I'm holding in my hand is a introducer, and that's going to be inserted into the patient. Next. So now you see it inserted into the patient, and in this case, I'm actually using something called pituitary rongeurs to grab some of the disc material and pull it out. So we're taking out some of the disc material actually mechanically, which is sometimes done. And next slide. And then we're going in with this heating device, which is actually radio frequency heating. And we're heating up the internal disc and the annulus on our way out to help close the annulus. And that may be the next one. Oh, then I put a little platelet-rich plasma, which is a way to decrease irritation around the nerve root and help the annulus heal. So it's something being done a lot more commonly these days, but it's not necessary part of the procedure. It's just something I do. Next. Now we're doing so for the facets, I already have in this, it's essentially a big needle. It's called a TUI needle. It's essentially a big needle on down into the facet joint, and I'm taking this laser fiber and taking it and putting it right down on the joint and shooting the laser, and that laser gets pretty hot. It gets a few hundred degrees, and so it's creating some scar tissue right on the facet joint, and doing two things, really creating a little scar tissue, hopefully tightening up that joint capsule that's been injured. And there's enough heat, it happens to knock out the little nerve that's going just to the joint, nowhere else. It's so the patient usually, if you knock that nerve out, they also don't have pain in the joint. But we're hoping, because the nerve will regenerate over about 6 to 9 months. But we hope we've repaired the facet capsule, and probably 3 out of 4 times we have. 1 out of 4 the pain does, those facet joints come back, and patients need future care. But so that's I think that's our last. Is that our last slide, Elliot?
Yes, it is, Dave. And
okay.
I have a question for you. What percentage of doctors in this field actually perform these minimally invasive surgeries?
Like we've just shown, there are very few guys across the country who do this. Probably, I mean, the ones that are out there, probably ones that we've trained, but I would say half a dozen across the country who are doing something like this.
Well, why is the number so small?
Because the interesting thing is, Medicare won't pay for minimally invasive. They'll pay for fusion surgery, but they won't pay for minimally invasive. It doesn't make a lot of sense. I've never understood it, but it's, insurance companies don't like to pay if they don't have to, and somehow they've gotten away from paying for these. And I think it's only time, as medicine keeps trying to save money over time. I think it's only time till they do pay. But for right now, they're not making payments. So the world of personal injury is the world where guys are doing most of this. And my answer was probably smaller than that, because there are guys who do occasional cases under work comp across the country. So there may be 25, 30 guys across the country doing these under work comp, but because work comp does pay for them too. But it just hasn't, in the personal injury world, for whatever reason, it really hasn't worked its way across the country. And so we've been out there, showing docs how to do this.
Okay. I'd like to let everyone know that we have the videos of these surgeries. They last 5-6 minutes. The several Dave just showed you. We have that on video, and we're happy to share with any law firms so that you could learn more about the procedures, and you can show the actual procedures in the future to clients that may wish to undergo the surgery, so they could see really, how simple and easy this whole procedure is. It's very educational for them. Now,
yeah, just so I'm clear, the actual surgery doesn't take 5 to 6 minutes, but the video is 5 to 6 minutes, right? Right.
Correct. Yeah, of course. Not that minimally invasive.
Exactly.
Now, we suggest an MRI of any client still complaining of ongoing pain after completing conservative care be reviewed. If your clients don't have an MRI, we can arrange to have that done for free. Now, prior to surgery, the surgery or the surgical evaluations are required for all patients to see if the surgery is appropriate, and a surgery cost letter will be given at no cost. The total confirmed liability limits we recommend are generally in the $75,000 range, but sometimes cases can be done with less coverage, and we can discuss that with you if you have such cases. For cases that were not approved for the procedures Dave just outlined, interventional pain injections can be performed as well. The estimated global fee include the surgeon, the hospital, and the anesthesia fees. Now, our program highlights, many of which we've already discussed, but I'll just go over them again. The care rendered by our physicians and facilities are all paid by us promptly, right after the care is given. It's all non-recourse. We're bearing the risk and hold the lien on the case. Our staff will coordinate all the client appointments and care, freeing up your own staff. So we're taking that off of you to make sure people show up for appointments, etc. All of our doctors provide the treatment records at no cost to you. And if the results, if the settlement or outcome is disappointing, we work with you. We're flexible as to what we can take, and we want to be your partner going forward. Now, if anybody wants the web copy, or I should say this webinar copy sent to them, be sure to email me. If you want to show this to other firm members, they could see just what you've seen. Just email that request to estone at medquestltd.com. Again, medquestltd.com, and we'll open it up to any questions anyone might have.
Let me add one thing while you're waiting for questions. So I just want to reiterate that what Elliot said in the beginning was that this is a niche area that we have found that patients who will often refuse to have open surgery are usually open to this kind of surgery, and so that's why I think Elliot said increase your soft tissue cases by 50, 100,000, meaning a lot of those cases would otherwise settle for small amounts, but because they've now agreed to a surgical a surgery, it
No.
basically increases the value of the case.